Hey there, folks. My name is Dr. Ashakie Phillips. My pronouns are they and she. I am a family nurse practitioner and I am a psychiatric mental health nurse practitioner student at Duke University School of Nursing. Today, we're going to be chatting about implementation of ketamine into practice, specifically for treatment-resistant depression. We're also going to be paying particular attention to what the implications may be for the psychiatric mental health nurse practitioner when they're implementing ketamine into practice. Now, our objectives for today is we're going to chat about the state of the evidence regarding ketamine therapy for treatment-resistant depression, and we're going to do this through the lens of a SWOT analysis. Furthermore, I'm going to help you understand the ways that the nurse practitioner can navigate threats and weaknesses if you decide that you want to implement ketamine therapy into your practices. And we're going to do this by discussing opportunities for change. Now, before we do this, I do want to give you a brief synopsis of what ketamine therapy might look like in a ketamine clinic. I decided to highlight the workflow from my personal clinical rotation this fall because I think that what they do is so intricate and beautiful. Now, you may have noticed that there's some virtual or run-of-the-mill ketamine clinics that are popping up, and they might be delivering ketamine to your door and saying, "Have a good day," similar to what we might expect from a dispensary. However, throughout today's presentation, I'm going to be discussing ketamine therapy through an ethical lens, where the provider does their due diligence for reducing harm by completing a comprehensive medical and psychological evaluation, providing anticipatory guidance and comprehensive education, including all treatment options, not just ketamine, discusses readiness for change and preparation for ketamine therapy, provides diligent, ongoing monitoring throughout medication treatment, promotes aftercare treatment and guidance, and most importantly, equips the client with an intricate and detailed plan for therapeutic integration after medicinal treatment. So first, let's start with the basics. So ketamine and esketamine, they sound the same because, well, they almost are. Anytime I say ketamine, typically I'm talking about racemic ketamine. And racemic ketamine, it's made of both isomers R-ketamine and S-ketamine. It's a dissociative drug, meaning it creates trance-like feelings and can significantly distort your perception of sight, sound, and even touch. Because of this, you may have noticed that ketamine is used by some folks recreationally, maybe in the party scene. However, also because of this, since the 70s, ketamine was FDA approved for induction and maintenance of general anesthesia. Somewhere along the line, researchers noticed that ketamine has antidepressant qualities. In particular, they noticed that this antidepressant effect was in relation to how it works with the NMDA receptor. So, they isolated the S isomer of racemic ketamine, which is known to have 4 times greater affinity for the NMDA receptor, and created what we know as S-ketamine. Now, in order to truly bring light to the biggest strength of these medications, you've really got to compare them to what we know about quote-unquote traditional antidepressants. I don't like to use that term because these medications do so much more than simply reduce depression, but for simplicity's sake, we're going to use that term today. Now, S-ketamine, it's pretty much the first new quote-unquote antidepressant FDA approved in the last 30 or so years. And that's a big deal because antidepressants traditionally, they were thought to only exert their force by modulating monoamines. And typically this was through monoamine oxidase inhibitors, tricyclic and tetracyclic compounds, and selective monoamine reuptake inhibitors. And while these antidepressants can be effective, they typically took several weeks of continuous treatment for them to have any type of clinical significance or show therapeutic effects. Furthermore, there's definitely some clients that are prone to symptom relapse or may fail to respond to treatment altogether, And then they're limited in what choices they have after using a multitude of these medications. Quite frankly, it's estimated that 1/3 of folks do not achieve sustained remission with these traditional treatments. Furthermore, some of these side effects, in addition to some folks not even achieving remission at all, can lead to negative coping skills like substance abuse, deliberate self-harm, even attempted or completed suicide. For these reasons, novel antidepressant treatments like ketamine and esketamine is actually one of the most urgent and clinical priorities that we face today. Now, fortunately, ketamine appears to provide a new approach to treating depression, while also alleviating some of those barriers that we talked about. Quite frankly, it's, fascinating how it's hypothesized that ketamine even works. They say that ketamine is a non-competitive open channel inhibitor of the NMDA receptor, like we chatted about before. Specifically, it binds to the phencyclidine site of this receptor. This leads to downstream glutamate release and consequential stimulation of other glutamate receptors, including the AMPA receptors. Theoretically, the reason why these antidepressant effects happen is because activation of the AMPA receptors leads to activation of signal transduction cascades that can cause the expression of synaptic proteins and increase the density of dendritic spines. This is known as synaptogenesis, and this process can affect mood, thought patterns, cognition, and even memory. And the strengthening of these synaptic connections can even lead to long-term potentiation, which means greater reduction in symptomology and creating new neuronal connections that can even prevent relapse in the future. I digress. All of this goes to say that ketamine and esketamine, not only can they provide rapid potential reduction in depressive symptoms, noted almost immediately after a single dose, they can also rapidly decrease suicidal ideation. And this can be quite life-saving in a crisis setting and can be noted in as soon as within 24 hours after treatment as well. Now, given the current limitations of most existing treatments for reducing suicide ideations and plans in folks with major depression, this additional property of ketamine is life-changing. Ketamine also has quite the versatility in comparison to traditional antidepressants, which typically are by mouth. You can take it by IV, injection, a nasal spray, even sublingually. It is important to note, though, that racemic ketamine or ketamine, it hasn't been FDA approved for depression. However, it has been known to experimentally be used for treatment-resistant depression with great results. And remember, 1/3 of folks with traditional antidepressants don't achieve sustained remission. So this is an incredible option for 1/3 of folks that don't have any other options. Also, esketamine actually has been FDA approved, but only as an adjunct, and specifically for treatment-resistant depression or major depression with acute suicidal ideation or suicidal behaviors. And of course, only for adults in both scenarios, and only as an adjunct with esketamine in the form of an intranasal spray. Now, of course, while this is a great option for folks who have no other options, of course, there are going to be some weaknesses. So in the, basic premise of a weakness, the side effects, right? Ketamine, some people get anxiety, headache, nausea, sweating. Esketamine, some folks get dissociation, dizziness, nausea, fatigue, increased blood pressure. Quite frankly, I think that those are both side effects for each other as well. Definitely folks taking ketamine through IV may get dissociation or dizziness, and definitely some folks with esketamine can have sweating, and so side effects for both, in my opinion, would be similar. And then let's be real, in terms of long-term or cumulative adverse effects, there's very limited data. And so we don't really have the best anticipatory guidance education to provide our patients in terms of what may happen 10 years from now or 20 years from now. But of course, again, this is for treatment resistant depression. So this is for folks who have tried other things that haven't worked and they don't have other options. And so while we may find out long term that there are some significant things going on, right now, right here, this person needs treatment. And so I would say that the benefits significantly outweigh the risk for the majority of folks that are receiving ketamine therapy for treatment resistant depression. Of course, other weaknesses are going to be the feasibility in clinical practice. Let's be real. Firstly, there is an abuse potential because some folks use ketamine recreationally. And so you do have to be on the watch for malingering, right? And then feasibility is so real when it comes to chatting about costs and accessibility. Now, let's just chat about what that looks like. Ketamine, it's 5 to 6 infusions over the course of 2 to 3 weeks, followed by maintenance therapy as needed, and appointments are about 90 minutes. S-ketamine, it's about 2 times per week for the first 4 weeks, followed by 1 time a week for the next 4 weeks. Then every other week is needed, and typically those appointments are about 2 hours. So imagine what that's going to look like in your practice if you have to be with a client for 1.5 to 2 hours throughout your day. Of course, that's going to limit the amount of clients that you can see per day. And if you were to hire folks to sit with these clients instead of you, because we do have to monitor their blood pressure, heart rate, be there if they need anything, etc., then that's going to cost even more money, right? So you're having less clients that you're able to see and more staff that you need within your practice. That's expensive. And that's just for you. Now let's chat about how accessibility even significantly decreases when we talk about costs for the patient. Although generic ketamine is pretty cheap, it's not FDA approved. So getting your insurance, or the client's insurance rather, to cover your visit for ketamine, it's going to be pretty much nearly impossible. Now for S-ketamine, it is FDA approved, but it's still going to be some barriers there to get the insurance to cover your visit because we're talking about treatment-resistant depression. You have to be able to prove that your client has treatment-resistant depression. And then there are, of course, going to be folks that don't have insurance or are underinsured, and that's even more of a cost for the client. That's why you actually see a lot of ketamine clinics don't even accept insurance at all. They pretty much just say, hey, we are pay out of pocket only, which provides even more barriers to access for many folks. And so feasibility in clinical practice, it is a beast, let's be real. It is something that definitely still has to be worked on and teased out by some of the stuff we'll chat about in a couple of slides. But it is real when it comes to whether or not you really want to implement ketamine therapy into your practice. What's even more real is the lack of regulatory guidelines. I don't know if you noticed earlier, but I said ketamine therapy, it's going to be followed by maintenance infusions as needed, and S-ketamine every other week as necessary. Now, what does that mean? There is no guideline out there that is going to tell you, hey, our evidence shows that this is how many responses are needed, or this is what the symptomology needs to look like in order for you to continue by X more infusions to achieve Y. Like, that's just not a thing. And so it's kind of a dance between you and the client as to what that looks like, setting up your SMART goals, determining how many more infusions that means after the goals have been met. That's a bit of a gray area, especially when it comes to getting sued, right? Because you have to prove that you went with your most prudent and utmost diligence using the best evidence and by the code book of the ANA to say you did what was best for your client and what most other providers would do. And how would most other providers do the same thing when there's no guideline to show exactly how you should be doing this treatment, right? And so that indiscretion among providers can be kind of tricky. And so you definitely have to dot all your I's and cross all your T's when it comes to ketamine treatment. Same thing goes for monitoring requirements. With esketamine, they do require that you have the REMS, so the risk evaluation and mitigation strategy, done throughout your esketamine treatment, but it only monitors dissociation, sedation, and blood pressure. That is, like, in my opinion, not enough as a standard of safety for monitoring. Like, we're not even monitoring some of the basic side effects like dizziness, nausea, anxiety, headache. Like, somebody's blood pressure can be going high and they can be getting a stroke and X, Y, and Z, but all you have on paper is their blood pressure. You don't even have, if you ask whether or not they have a headache. So, in my opinion, I think that the monitoring requirements are pretty weak when it comes to esketamine, and they're just kind of just not there at all when it comes to ketamine. And so it's really up to clinician judgment for what that looks like, both acute and long term. And so that can make it a little bit more difficult for you as well. And of course, those weaknesses lead to a lot of the threats that exist. We talked about the risk for abuse. Now, while there haven't been very great data telling us what long-term adverse effects can look like for folks who are treated with ketamine clinically for treatment, there has been some data to suggest that if you overuse or abuse ketamine chronically for recreational purposes, there's a risk for urological toxicity, hepatotoxicity, cognitive defects, dependency, even long-term cognitive and memory impairment. And so that threat, of course, does exist. And then again, you're using racemic ketamine off-label. And so the liability and the insurance coverage are going to be really tricky. And then we already chatted about safety monitoring, how it's just not clear what that long-term harm or adverse events look like. And the research funding and support there is significantly lacking. I mean, there's so much money for so many other things that we're researching. I genuinely feel like ketamine, because we're on the brink of such a big breakthrough when it comes to treatment for depression, there really should be so much more research there and funding for that research. And then, of course, public perception, stigma, that's going to be a huge threat. You might be known as the provider that provides ketamine, and you're the ketamine provider now, and then now you have a lot more clients lingering. Or you might be the clinician that is not respected in the community because you're quote unquote providing drugs to the community and somehow providing more problems for the opioid crisis, even though it's not an opioid. But I digress, you understand. And then, of course, there's lack of equitable access. So you might even be creating more disparities for marginalized communities if you're just setting up this same similar concept of ketamine therapy, pay only, no insurance acceptance, and insurance aren't covering it. You might be setting up for more disparities and not even knowing. And then again, there's so many for-profit entities and there's so much market competition that ethical concerns become a huge part of your practice when it comes to setting up a ketamine clinic. Because are you low-key becoming one of them, or are you staying and maintaining the provision of an ethical provider? It's kind of murky sometimes when you bring about those weaknesses and those threats and those issues that you have with setting up a ketamine practice, while also trying to balance it with sustainability and realistic expectations in order to keep the practice growing. Now, that being said, yes, those are some pretty intense weaknesses and threats when it comes to ketamine therapy, but I do strongly believe that psychiatric mental health nurse practitioners can very much navigate those issues and even create opportunities for future providers like themselves to have significantly less problems and significantly more cohesive practices, more ethical practices, and a beautiful layout of a foundation for how we can have ketamine therapy be a wonderful option for folks with treatment resistant depression. So, for one, obviously, a big issue is that there's no monitoring and safety protocols that are that great. Now, there are some evidence based guidelines out there. They're not like quote unquote protocolized, like we don't have the American Academy of Nurse Practitioners saying, hey, use this tool for ketamine, and neither do we have a society out there saying, hey, for all of those with ketamine clinics, this is what you should do. And we definitely don't have the backing of the American Nurses Association saying, we support this, do this guideline. Like, no, it's not there. But there are some tools out there like the KMET tool that provides some other additional things that they think you should be doing during your screening, your baseline, acute treatment, and follow-up visits to help you further gather information to make sure that you're doing your due diligence for this client. Also, don't forget that as nurses, we are the best advocates out there. So I think that we should do our due diligence in advocating for and maybe even working towards creating evidence-based guidelines ourselves that maybe can be supported by some of those organizations. Also, there are ways out there that we can work towards decreasing cost, right? So for one, if we can integrate ketamine practice into primary and mental health care, we might be able to leverage getting coverage by insurance for some of these visits. We might also be able to utilize like sliding scale fees that FQHCs often provide in order to cover the cost for some of these visits for certain populations, like folks that are underinsured or uninsured. Also, you can do group therapy that provides a significant cost reduction for the practice or for you in general if those staff that you typically had to have there for every single visit could be there for this one big visit with like 10 people at the same time. You're reducing your cost tenfold. And then again, offering sliding scale options, maybe you can decide what that means for you. Maybe for folks with certain disabilities or from certain marginalized groups or ethnic backgrounds or income limits can have specific slots within your practice that is reserved just for them to make sure that you're not increasing disparities for certain marginalized groups. And maybe you can be a part of the folks down at the White House or wherever you need to be advocating for insurance coverage. Like MAPS is an awesome organization. They're called Linkos now, that does a lot of advocacy, a lot. And they're constantly having roundtable talks. They're writing up X, Y, and Z to the FDA. They're at the White House. They're constantly doing advocacy. And so maybe your way of helping out is by joining an organization around the globe that advocates as well. And again, a huge way to decrease cost is making sure that you have top tier malpractice insurance. I'm talking like multi-leveled for the practice, for you, for everybody under you. Because say if you were to get sued, you definitely want to make sure that you're covered. And again, nurses, we do research too, right? So maybe we can look up alternative administration routes for our ketamine or the generic ketamine, because maybe it'll be cheaper. Or maybe we can help do research on long-term side effects or adverse effects. Or maybe we can advocate to expand FDA indication by simply just being a part of the research for FDA approval. Again, MAPS, Linkos, they're a huge entity when it comes to pushing forward the cause when it comes to getting FDA approval for psychedelic substances. And then for clinician education and collaboration, again, participate in FDA approval. If you don't want to be a part of the folks on the ground with picket signs, you can still at least sign up to be a multi-site data collection, right? Maybe you can be a site that sends all of your information regarding your clients within your practice in terms of their short-term or long-term side effects that they might be experiencing to the FDA. And so you can help collect that data that's needed to push forward with approval of racemic ketamine, right? And also, you can do such beautiful work simply by just chatting with other clinicians to reduce stigma and increase awareness. And definitely make sure that you collaborate with providers who are also doing this work so that you can have supervision in place and have a referral list. Because again, those guidelines are pretty murky. And so, working with other folks who are also doing the work so that maybe those guidelines can become a little less murky for you is always a great idea. Always have a referral list. Maybe if you've run out of spots for folks that you can do sliding scale fee for, maybe there's somebody else in the community that you can collaborate with that has a slot open. And again, this helps promote equitable approach to access. And so these are some evidence-based ways that nurse practitioners can help navigate some of those weaknesses and threats. But me personally, I also recommend that it would be so cool if folks did some work or research or even just implemented and see how it went with combination of ketamine or S-ketamine with complementive and alternative medicine therapies that we know help with depression, such as music therapy or breath work or meditation or art therapy. There really isn't much research out there that says, like, hey, if you use S-ketamine and integrate music therapy for folks that have X violence during X, Y, and Z, that maybe Y, Z, and X, it just doesn't exist, folks, is what I'm getting at. So maybe you can be a part of the change by doing some research or implementing into your practice some other versions of complementive and alternative medicinal therapies to see how we can further augment the beautiful properties of ketamine. And then, of course, some other things that I think would be really cool to do research on is genomic integration and indication. We're seeing here that we're doing ketamine therapy for folks with treatment-resistant depression. What if there's some type of genomic indication that a lot of these folks share that show that maybe before they even start those SSRIs or other traditional antidepressants, that there was already some genomic variability that shows that maybe ketamine should be your first line treatment, right? And so I think that would be really cool research to do in the future, and I look forward to finding out what that looks like. So thank you, folks, for being a part of my presentation today. Here is a list of references that I welcome you to check out.